So it will be broadly, your study and your discussion will be on etiopathogenesis, clinical features, investigations, implication on health and fertility, and management. You can expect a long question from each one of these subtopics. So what is the definition? It's a benign disease of the female reproductive organ causing chronic inflammatory reaction which is locally invasive and disseminates widely. It is due to the presence of functioning endometrium, stroma and glands in the anatomical sites other than the inner lining of the uterus. It is not a neoplasm, but it behaves like that, but malignant transformation is occasionally present, not always. And it is endometriosis in extrauterine sites, and adenomyosis is present in the uterine wall. Can one of you please define endometriosis? It is sometimes present in the uterine wall itself. That is called adenomyosis. That is adenomyosis, and the rest that you have said, that is endometriosis. Thank you. Its prevalence is around 10%. Real prevalence is due to delayed marriage, postponement of first conception, adoption of small family, and it is apparent through diagnostic laparoscopy. When you do laparoscopy, this is the most, it is a gold standard of diagnosis. You can see it. And the other evidence is indirect evidence. It is present in 30 to 40% of infertile women, and in India we have 42 million people suffering from it, this amounting to 10% of the reproductive age group and contributing to 25% of the global burden. So this is a social burden. It interacts with the quality of life of a woman. So this is just to give you an idea. It can be present in the uterine wall, in the bladder, in the gut, and it can all cause adhesions with each other. So these are the possible sites where it is present. Commoner sites are the ovaries, the pelvic peritoneum, POD, the uterosacral ligaments, rectovaginal septum, sigmoid colon, appendix, pelvic lymph nodes, and fallopian tubes. Rare sites, occasionally you will find it in umbilicus, abdominal scar, episiotomy scar, even as far as lungs, pleura, ureter, kidney, arms, legs, nasal mucosa. These are rare, but it can happen. It is due to estrogen dependency, retrograde menstruation, angiogenesis, local inflammation, oxidative stress, stem cell theory also comes into it. So these are the various theories proposed why that endometrial tissue has transported to such a place. It is ectopic. It is ectopic presence of uterine glands and stroma outside the endometrium. So how did it deport to that place? So these are the theories that have been proposed. This is a long question. Samson's theory regarding retrograde menstruation means menstrual blood should flow out, but this is a retrograde, that is, it's a reverse flow of the menstrual blood which is causing it. This is the Mayer-Ivanhoe theory of Celomic metaplasia. That means it has changed at the site. There has been a metaplastic change in those tissues where it is present. That is how it has been converted to endometrium. Mullerian remnant theory, that is atypical migration or differentiation of these remnants. There were Mullerian remnants, means these are congenital remnants present, and this has differentiated to form this endometriosis. Direct implantation, endometrial tissue has been transported directly. When we do surgery, some amount of endometrial tissue can come out and implant on the surrounding surfaces, and it can be also due to, lymphatic or vascular metastasis theory. It has spread through lymphatic or vascular system. So this is how we explain the presence of pelvic endometriosis. We can say it is due to retrograde menstruation. But what about peritoneal endometriosis? This is due to coelomic metaplasia. Coelom is a cavity, and the lining epithelium has changed into endometrium. So This could happen from progenitor cells that were present there, or Mullerian remnants, or transplant. So, abdominal viscera, rectovaginal septum, umbilicus, all can be explained by coelomic metaplasia. And the abdominal scar, in a caesarean scar, you can get a caesarean scar endometriosis. So, that comes from direct implantation, even in the episiotomy scar, vagina or cervix. Lymph nodes, lymphatic spread, and distant sites, of course, this can be explained by vascular spread, genetic predisposition, or immunological factors. So, this etiopathogenesis question you can expect. So, please go through this theory part, and you can give a diagrammatic also. This diagram, the schematic diagram that we have given, this can be given. The stem cell theory, now certain new theories have cropped up. Oxidative stress, there is an imbalance between the reactive oxygen species and the body's antioxidant ability. There is a role of interleukins. You have studied in pathology chronic local inflammation due to interleukins. This causes chemotaxis, recruitment and activation of peritoneal macrophages and proliferation of monocytes. Tumor necrosis factor in the peritoneal fluid is also causing this inflammatory response. Estrogen is the predominant hormone. So, to treat this disease, we have to counter the effects of estrogen. We have to counter the effects of inflammation. And there are certain genetic factors which we cannot fight. So, we have to fight against the hormonal factor, the immunological factor, and the inflammatory factors. Epigenetic factors are also important. This is an undeniable factor in the pathogenesis of endometriosis, and this is demonstrated by the fact that not only women of reproductive age suffer from this, but also adolescents and younger women with family history. So, there is a genetic predisposition. This has been identified and makes some women more prone to this disease than others. So, these are the risk factors. Low parity, people get pregnant lesser these days. So, there is a more chance of when there is pregnancy, periods are, there is amenorrhea. So, there is no period, and so if you explain it by the retrograde menstruation theory, if there is no period, there is no retrograde menstruation. So, there is less of endometriosis. But if the number of pregnancy is less, so a woman is ovulating more and the periods are also more frequent. So, there are more chances of endometriosis. Previously, multiparous women used to have less of this disease. Do you understand this factor? Less periods, less endometrial transportation. So, there is less of endometriosis. Late pregnancy is another factor, and family history of endometriosis. Genital outflow tract obstruction. Certain outflow tract obstruction can encourage retrograde menstruation. That means the menstrual flow is obstructed and that is going retrograde. Retrograde means reverse flow. Menstrual blood should come out through the cervix and vagina. That if it goes towards the tube, ovaries, etc., it spills over into the peritoneal cavity. Imagine the anatomy, you will understand this. Do you understand this point? And environmental toxins like dioxins, chlorinated biphenyls, heavy metals and endocrine disrupting chemicals. There could be some molecular defects also. These are the things that we are talking about, molecular defects: cytokines, tumor necrosis factor, macrophages, extracellular matrix metalloproteinase, tissue inhibitors and extracellular matrix metalloproteinase inducers. So, we have more of inducers and less of inhibitors. This encourages this endometriosis to spread. Interleukins, microRNA and vascular endothelial growth factor. There are new vascularization, angiogenesis and less of apoptosis. If apoptosis means tissue, the cell death, there is more of proliferation and less of death. So, endometrial tissue flourishes and that causes the endometriosis. So, the balance between angiogenesis and apoptosis is affected. This is all etiopathogenesis. You have to prepare a long question on this. Please keep it in mind. If you don't understand, please ask. And this is in nutshell that I have been discussing, the molecular theory. It is estrogen dependent inflammation, so there is hormones, immunity, cytokines and genetic factors. These 4 factors come into play. So this is these are the 4 factors. This we have discussed. And the pathology is functionally active ectopic endometrium is causing this. This proliferating changes, cyclical growth and shedding, and the blood being very irritant, that invites inflammation. And then we have chocolate cysts. This is chocolate colored fluid, that is blood, altered blood, assumes the color of chocolate, brownish in color. And in spite of dense adhesions, fallopian tubes remain patent. This is very characteristic of endometriosis. The macroscopic features depend upon the extent of the organ involved, extent of the lesion and the reaction of the surrounding tissues. Have you seen any operation on endometriosis? Have you ever seen? In gynae operation, it comes out like chocolate colored fluid. So it can present as small black dots, fibrosis, yellow patches, white patches, and the ovaries are frequently involved, and it causes endometrioma, that is ovarian endometriosis. It causes a cyst to form and it is staged as minimal, mild, moderate, severe. This is another question. The staging of endometriosis. It can broadly, clinically, superficial peritoneal endometriosis, ovarian endometrioma and deep infiltrating endometriosis. These are the 3 clinical parameters of endometriosis, broadly speaking. This is superficial endometriosis. This is how we see under laparoscopy. See the powder burn appearance of the endometriosis. It's like matchstick burn. This is ovarian endometrioma. We had operated on these patients. This is how it appears like. And this is deep endometriosis. So the gut, ovary, POD is all clustered. You cannot separate them. It looks like malignancy, but it is not malignancy. You can separate them. There is a plane, but due to blood, endometrial tissue, this has occurred. The microscopic features, you have to have endometrial gland and stroma to diagnose it as endometrial deposits, and the lining epithelium gets flattened out and it is replaced sometimes by granulation tissue. Large polyhedral phagocytic cells laden with hemosiderin. Where does the hemosiderin come from? Hemosiderin is coming from what? The macrophages have engulfed it. What is hemosiderin? It is a product from blood. So that is why this is present. Cyst wall is composed of fibrous tissue and compressed ovarian cortex. The clinical profile is somewhat like this. High social status, age is around say 30 to 45, late pregnancy, 1 or 2 children, subfertility, family history and outflow tract obstruction in adolescence. Sometimes say cryptomenorrhea. What is cryptomenorrhea? Outflow tract obstruction of the vaginal outlet. So there is a imperforate hymen and the blood accumulates and it can cause endometriosis because there is retrograde flow. The outflow tract obstruction, the blood cannot come out. So there is a chance of retrograde flow. That also can cause endometriosis. So patients present with pain, some are asymptomatic, they don't have anything. It is not related to extent but depth of penetration. If it is more than 5 millimeter, you can expect pain. Patient might say she is having pain. Non-pigmented lesions are more painful due to prostaglandin F and related to site and hormone sensitive. Midline lesions are more painful. Degree of pain is not related to severity. And this is the causes of pain is this. There is inflammation, necrosis, adhesion, nerve irritation and release of local inflammation. Any pain that we perceive, this is due to these causes. So endometriosis is no singularly different in character. This also is produced by the same way. Symptoms are patients may present with dysmenorrhea, dyspareunia, chronic pelvic pain, abdominal pain, dysuria, dyschezia, low back pain, Catamenial chest pain. During periods, patients present with chest pain. That is how you explain endometriosis having distant metastasis, distant transport of endometrial tissue and cyclical plane. So, this is all pelvic endometriosis and this is extrapelvic endometriosis in lungs and in scar endometriosis. Clinical features depends upon the organ involved. There is abnormal uterine bleeding. If the uterine wall is involved, then we have more of bleeding. Patients may present with infertility. That is two chief complaints, pain and subfertility, usually with this. And along with endometriosis, we have adenomyosis, that is the uterine wall is also affected. Then we might have an abnormal uterine bleeding. Diarrhea, constipation, hematuria, chronic fatigue, hemoptysis and bleeding from surgical sites if there is scar endometriosis. So, what will you expect how will you examine a patient? Suppose a case is given, the patient comes with cyclical pain and she presents with may or may not have an abdominal mass. There is tenderness, restricted mobility and bimanual examination may not reveal anything. But sometimes the patient present with pelvic tenderness, nodules, fixed uterus. Uterus is not mobile. Why? Because there is adhesion with the gut, retrofixed, retroverted. Uterus is not, normal position is anteverted, anteflexed. Here the uterus is getting retroverted because of the adhesion behind with the gut. This is how it can present. Unilateral mass, that is adnexal mass with ovarian mass, and per speculum you may see bluish spots in the posterior fornix. A rectal examination may also be helpful. The diagnosis can be made clinically by markers and we have several markers. These are other markers, but commonest marker is CA125. And differential diagnosis, it can mimic chronic pelvic infection, benign ovarian tumor. So, you can have a differential diagnosis. A patient can come with a lump. This could be due to so many causes. So, this is the, these are the DD. Benign ovarian tumor, malignant ovarian tumor, acute abdomen due to disturbed ectopic ovarian tumor, torsion, rupture, appendicitis, diverticulitis, all may simulate a ruptured chocolate cyst or endometrioma of ovary. See, when it ruptures, it is only old blood coming out, that is very irritant. That can present as an acute abdomen. So, how will you investigate? Ultrasound is very informative. You can do MRI, you can do CT, useful in deep infiltrating endometriosis. IVU can be done if you suspect ureteric involvement. So, how will you manage a case? You have to clinically ascertain whether she is having endometriosis, then do the investigations and then treat her. This is how it looks in a USG of an endometriosis. See the hypoechoic shadow, there is blood inside. So, it is hypoechoic. Endometrioma, see CECT, it is also hypoechoic. These are the bowel endometriosis and this is ovarian endometrioma. MRI also by T1 and T2 images, if you have OSPE, you can get these as your OSPE. You have to identify that. This is how it looks in laparoscopy, and you can do rectosigmoidoscopy, cystoscopy or colonoscopy if you suspect that the patient is having bowel endometriosis. Said laparoscopy is the gold standard. We can see what it is. All these are indirect evidence. Imaging is an indirect evidence. Clinical features we are suspecting, but this is absolutely we are seeing. Why it is very beneficial? We can see the site, take a biopsy, you can take a tissue from it and test it for biopsy. For why? Because there is a remote chance of malignancy also. So, it is not very common, but we can see it. Staging can be done and you can record it. Everything can be recorded these days, and laparoscopy surgery can be done. Now, staging is important to predict diagnosis, to choose the therapy, what therapy you will do, and to evaluate the treatment protocol. See, endometriosis is a very difficult disease. Till now, we have still going on trying to explain this disease. This is an enigmatic disease. Last week we had a conference on endometriosis, International Congress on Endometriosis. So people are still finding reasons or to how to treat it. This is how the staging is done. This is minimal, mild and moderate, severe. These are the 4 stages, and we principally speak of endometriosis in terms of peritoneal involvement and ovarian involvement, posterior cul-de-sac involvement, and adhesions. It can be filmy or dense. This is how the scoring is done. So this staging also, you have to have an idea how it is staged. But we have limitations. This is staging cannot be done, we have to do an operation. So it is invasive. Inter and intra-observe, I am finding something, you say this is not that. So that could be an observer variation. Staging does not always corroborate with severity of symptoms or fertility outcome. Staging of disease not corroborative with treatment protocol at times. But this is the only way we can come to a standardized treatment management protocol. This is commonly followed and we try to treat it. This is the laparoscopic, this is a post-operative view. This is the uterus after the cyst has been removed. This is the chocolate cyst that is coming out. This is the video. The cyst, the chocolate cyst that you see, it has ruptured and the chocolate cyst is coming out. We can take biopsy, but negative histology does not always rule out. If you don't get endometrial stroma and glands, it doesn't mean that it's not endometriosis. But if you get, that is a positive impact. Now, how does it affect fertility? This is an important question. So, these pelvic cavity is involved. So, we have inflammatory changes. This causes alteration of sperm and oocyte interactions. So, distorted anatomy, there is failure of ovum pickup. Transport is affected. Ovaries, there is less ovarian reserve, anovulation, luteal phase defects and poor response to ovulation induction. And in uterus, there is receptivity, implantation failure. So, at all levels, see the sperm transport is affected, ovarian tissue is affected, the number of reserve is affected, implantation is affected and pelvic pain and dyspareunia, this causes coital difficulties. So, the whole pregnancy, the fertility potential is affected. Why this endocrinopathy? You must have an idea. There is corpus luteum insufficiency, so less of progesterone, more of estrogen. Progesterone has to be present. That is deficient here. Luteolysis due to prostaglandin F2 alpha. This is the inflammatory response. Then anovulation, prolactin level goes up. This disturbs the hormonal milieu and there is ovulation disturbance. Complications are leading to subfertility. Rupture can cause acute abdomen. This can, chocolate cyst can also rupture, and obstructive features, if it involves the gut, this can cause subacute obstruction, ureteric obstruction. If the ureter is involved, there can be hydroureter, hydronephrosis, renal infection and malignancy at times. 4-fold increase, commonest is adenoacanthoma. The treatment is preventive and curative. We don't have much preventive aspects, but a tubal patency test after curettage can be avoided, but these are not actual reasons of its presence. This was thought of, and curative, we have to minimize symptoms, improve fertility and prevent recurrence. This disease is notorious for its persistence, progress and recurrence. So, we have to arrest the disease, arrest the progress and encourage the fertility, how to stimulate the, how to improve the fertility. So, the challenges lie in these, the challenges of therapy. So, we don't know much about it, it's still obscure, we are still going on trying to find out the reason, but whatever we have known, this we have to fight with that. It's difficult due to lack of uniform staging, asymptomatic in certain cases and sometimes affected the fertility potential. Determination of treatment options depends on the age. What is the age of the patient? What is her fertility desire? And what is the symptoms? How severe are the symptoms? So these are the factors which will affect the treatments. How will you treat the patient? This can be a question. How will you manage the patient? Depending upon these parameters. So treatment may sometimes expectant, don't do anything. But this is also very doubtful because some patients will progress. So you have to treat at the earliest. We have medical treatment, surgical treatment and combined treatment. Expectant, it is progressive in 30 to 60%. So we should treat them. Unpredictability of progression. Some form of treatment is required. Role of treatment in minimal and mild is controversial, but empiric medical treatment not recommended except for pain relief and AUBE, that is endometrial factor of abnormal uterine bleeding. So we can give NSAIDs or like ibuprofen and mefenamic acid. These are anti-inflammatory drugs. If the patient responds to it, fine. And we have to case selection for expectant treatment. Minimal cases, unmarried, young, married, desirous of family, approaching menopause, these will direct it. And this is the medical management. You have to know this. The combined OCP, progesterones, oral, MPA, medroxyprogesterone, dydrogesterone, norethistron, and Dynogest is a golden drug now, almost a first line drug. This is 4th generation progesterone. So medical management of endometriosis you must go through and learn, and this is injectable MPAs can be given. IUCD LNG is Mirena. This is intrauterine administration of levonorgestrel. This can, so what we are trying to do? We are trying to counteract the effect of estrogen with progesterone. Sometimes we give combined OCP to prevent pregnancy because patients perhaps are not desirous of family right now. And androgenic steroid danazol is not used nowadays, but you can mention it because it was used in the previous years. And others we have GnRH analogs. So if you have GnRH analogs, that will stimulate the GnRH receptors. So there is a less, they compete with the gonadotrophins, less gonadotrophins will be released, less of hormones, less of estrogen. So this is how GnRH analogs work. So we have injectable preparation. Nowadays we have a GnRH antagonist, that is it will block the receptors. So these broad classification you have to understand. This is elagolix, this is orally active. All these GnRH analogs are injectables. We cannot give it orally because this is a non-peptide. That is why we can use it orally. So now we can use this also for 2 years consecutively. So that will reduce the pain, the bleeding, but pregnancy has to be deferred. We can use others like aromatase inhibitors, letrozole, anastrozole, dopamine agonist, cabergoline, progesterone antagonist, mifepristone, selective progesterone receptor modulators, simvastatin, rosiglitazone. These are all on research levels, but this is the first line treatment, second line treatment. This is a crowded slide, but you can go through it. Broadly speaking, progesterone and first OCP, progesterone and GnRH analogs and antagonists. So we have to relieve the symptoms and reduction of volume of lesion, improve the fertility and prevent recurrence. So these are the 3 things we are fighting. So GnRH analogs cause quick relief, progesterones take time to respond, danazole is intermediate but not well tolerated. Following medical suppression or conservative surgery, residual endometrial lesions may regenerate once ovarian function is re-established. This is the peculiarity of the disease. You are treating and it is again recurring. Overall recurrence is almost 40% over 5 years. So we have been struggling so long, so many years to suppress this disease. So indications of surgical management, and if it is very severe, we have to correct the anatomy in case of DIE. Endometriomas more than 1 centimeter, now it has been taken as 3 centimeters, and also to improve fertility. Surgical management can be done. This is conservative, this is definitive. Conservative means just burn or ablate the endometrial tissue, or for pain relief you can do LUNA, that is laparoscopic uterosacral nerve ablation, excision of nodules, and endometrioma, aspiration and irrigation, cyst wall vaporization or cystectomy if it is more than 4 centimeters, 3 to 4 centimeters. So these are the targeted therapy. This is new ideas about endometriosis, absolutely target oriented therapy, because we just have to treat the lesion. We don't have to treat the surrounding organs. Other organs should be kept okay. We have to give therapy so that only the endometrial lesion is affected. If you are treating the lesion in the ovary, you are destroying the ovarian cortex also. Some ova are also destroyed. So this has to be kept in mind. Now, what about adenomyosis? This is a adenomyosis, anyone? What is adenomyosis? It is a condition where there is ingrowth of the endometrium or invagination of the endometrium into the myometrium. The junction between the endomyometrial junction becomes disturbed, the junctional zone is disturbed, and the endometrium ingrows into the myometrium. This will present mostly as pain and heavy bleeding. So the endomyometrial interface is affected. There is extension of the endometrial glands, and in absence of submucosa, the endometrial glands lie in direct contact with the underlying myometrium, forming nests deep within the myometrium, causing myometrial hyperplasia around the endometrial foci. So the blood is now, the endometrial tissue is within the wall. So the uterine contractility is disturbed, and patients may present with heavy bleeding and painful periods. So disturbance of the junctional zone on T2 weighted image on MRI. The innermost layer causes infiltration of endometrial gland and stroma to inner myometrial zone. So this is the same way it is happening, alteration in the utopic and ectopic endometrial factor. Utopic means the endometrial tissue that is present within the endometrium, that is utopic, normal side, and this ectopic is the abnormal side. Both the places there is a tissue injury, and angiogenesis is more, apoptosis is less, so the endometrial tissue is flourishing. This is tissue injury and repair that we have explained with cytokines and inflammatory response. There is more of adhesion molecules, proliferation and angiogenesis, that is more new vessels are growing, and cytokines, oxidative stress, and apoptosis is cell death. So there is uterine peristaltic activity, and sometimes genetic predisposition is also observed. So this is the pathology. The basal layer is not responsive to hormones. So this adenomyosis usually do not respond to medical management like endometriosis, because the basal endometrium is non-responsive to hormones. So we are in a fix now how to treat this, because endometriosis we had done medical management, surgical management at times, but here it is functional layer is responsible. Here the basal layer infiltrates, this is less responsive. Myometrial hyperplasia occurs, and there is a diffuse enlargement of uterus, more posteriorly, and may be localized or may invade a polyp also. This is how it looks like. You might get a specimen of this kind. See the globular look, and see the cut section, we don't have a distinct definition, a distinct capsule of a tumor. In the case of a fibroid, you will get a pseudo capsule. Here there is no capsules. So it is diffuse enlargement. See the posterior wall is more thickened. Size almost say 12 to 14 weeks. Cut section, thickened endometrial wall, and trabeculated appearance. Can you see this cut section? You can get a specimen of this kind. You might be able to, you have to diagnose this. As OSPE specimen, you can get this. And no capsule unlike fibroid, and visible blood spots may be found. This is the adenomyotic. So the endometrial tissue inside the myometrium. These are myometrial cells, and here the endometrial glands are present, glands and stroma within the myometrial wall, that is the muscle layer. This is the histopathology. So patients may present with all this. Again, 1/3 of patients will be asymptomatic, but others may present with heavy menstrual bleedings, dysmenorrhea, dyspareunia, and dyschezia. 3 Ds. Dysmenorrhea and dyschezia. Usually patients present with dysmenorrhea initially, but this cyclical pain sometimes get merged with non-cyclic pain. Patient complains of pain throughout the cycle. So there is a midline hypogastric mass and uniform enlargement of uterus, altered in case of associated fibroid or pelvic endometriosis. This can coexist. Endometriosis is also there, adenomyosis is also present. This can be present. It can be present with fibroids also. All these are estrogen dependent conditions. So they can coexist. So there is increased uterine, why we have heavy menstrual bleeding? Because the cavity has increased. There is endometrial hyperplasia, more the endometrium, more the bleeding, and inadequate uterine contraction due to distortion of the junctional zone. And the pain is due to the retrograde pattern of the uterine contractions, increase in the number and depth of penetration of adenomyotic foci, there is tissue edema and prostaglandins. Prostaglandins cause pain, you have to keep it in mind. These are inflammatory reagents. Impact on fertility, high incidence of subfertility, infertility, miscarriage, abnormal function of the because the implantation is affected, abnormal function of the subendometrial myometrium, retrograde myometrial contractions. So the contraction should come from cornu to the cervix. Here the reverse contractions occur. So that affects the fertility and interferes with the sperm transport and interferes in blastocyst implantation. Abnormal endometrial immune response and nitric oxide levels. So all this is affecting the fertility and the menstrual pattern of a patient with adenomyosis. How will you investigate? You can do USG and colored Doppler. See, it has 3 distinct zones of different echogenicity. Subendometrial hypoechoic zone is characteristic of adenomyosis. There is a heterogeneous echogenicity and hypoechoic myometrium. Why hypoechoic? Because the blood is hypoechoic. There is hypo and hyperechoic, you understand. We have taken classes on imaging. Hypoechoic means it is, you can see a black shadow, and hyperechoic is a white shadow coming. So here the blood is present, so you will expect hypoechoic shadow within the myometrium, and increased vascularity and ill-defined endometrial echo. So this junction between the endometrium and the myometrium gets fuzzy. That is how the ingrowths of endometrium into the myometrium occur. This is the MRI findings. See, if the low signal intensity of junctional zone is less than equal to 8 millimeter, it can exclude adenomyosis. If it is more than 12, this is adenomyosis. Please remember this. Just a small information, please remember this. And how will you manage? With medical management with NSAIDs, levonorgestrel and danazole, and no role of COC, because it is not hormone responsive. And surgically you can do adenomyomectomy, uterine mass reduction and uterine artery embolization, and definitive treatment is to remove the uterus. But I have talked about elagolix, that is a GnRH antagonist. This is a new drug in the market. This has been found to be somewhat, it can relieve the uterine volume, reduce the uterine volume, and can reduce the bleeding also. So it has been seen that patients with adenomyosis can respond to elagolix. This is under study, and also we have fruitful results for it. This is adenomyosis and how they converge. You see the adenomyosis in the wall and endometriosis is outside the uterus. This is how the same pathology in 2 different forms. So what is the take home message? Who considers endometriosis and adenomyosis a disease entity which can present with pain, subfertility, bladder bowel symptoms? So what are the 3 things that endometriosis present with? Commonest 3 symptoms. Please tell us. Anyone? Commonest symptom, how the patient will come to you, complaining of what? Anyone, please get up. Pain, and get up. Pain, if involved. So dysmenorrhea, pain will be a characteristic type, usually. Cyclical pain. Whenever she is having period, she is having pain, not otherwise. But with the progression of the disease, that cyclical pattern may change, and she may come with subfertility. Subfertility. This person can become pregnant someday. So don't stamp her as infertile. Say subfertile. And third thing is, she may come with other symptoms of endometriosis affection, that is dyspareunia, that is difficulty in intercourse, or dyschezia, that is difficulty in defecation. So these are the Ds, 3 Ds, and plus subfertility. So it has impact on sexual and mental health. The quality of life is compromised. Overall quality of life can be disturbed, and this can cause social and financial burden. So awareness programs are being conducted so that the society is aware of this entity. Just don't brush it off as it is normal, it always happens, so don't bother. It is not like that. So you have to give importance to it, because this lady may be having a very productive role in the society. Because of this disease, she can't. So help her to combat it. The awareness programs are there to sensitize the public and frontline health providers about its impact on a woman's health with socio-economic well-being. Early detection and available treatment options can give optimal result. So there is also a scope for multidisciplinary management, because the patient will not always come to the gynecologist. She may visit any physician. She may tell her close neighbors or close family members. So they will bring the patients to us. So there should be a social awareness about it. Endometriosis is an entity. It is so important. The whole world is thinking about it. Just now we have told you there was an international congress on endometriosis. So it is an important topic. It is just not happening to those who are affected. It is affecting the whole society at large. And for you, it is an important question for MBBS. UG students also should be having a good idea about it. Three questions you can: etiopathogenesis, management, and how does it affect fertility. 3 broad questions you should be able to write, and OSPE questions can come regarding the specimens can be given. Not of endometriosis, laparoscopy, this can be given, small OSPE can be given, or that adenomyosis specimen can be given the way we have shown you.